Good afternoon. My name is Annette Leibing from the University of Montreal, and I thank the organizers for inviting me to this very stimulating colloquium. Since the title was kind of imposed on me, I took the liberty to change it. So today I will talk about emerging global knowledge, dementia prevention, and the situatedness of clinical trials. When you saw the different chairs on the first slide, I wanted to call attention to what is central to my argument is nuance and diversity, but in reality, the chairs should be looked at as these ones. They are all entangled and smashed together, and still they have different colors, and soon I think you will understand why. So today I will quickly talk a little bit about what we call the new dementia and especially dementia prevention, about which I have published. Then I will compare early trials, early means here 2017, and compare Europe and the US. I also published a first analysis, and the third part is a work in progress, which is about the translations in Europe, US, maybe Canada soon, and Brazil. And since this is a meeting in which ethical questions are at the forefront, we could ask in this case, does it matter how and where science knowledge is translated and put into recommendations? And of course, I should also say that in reality, we should talk about risk reduction and not prevention. But since this is the term that's been mostly used in the media and in academic writing, I will stick to prevention, although it's not really correct. So you're probably aware, and I'm sure other speakers have talked about this. In 2017, it was the accumulation of knowledge. It actually started much earlier, already in the 1980s. But in 2017, a Lancet report came out in which they claimed 1/3 of dementia cases may be preventable, and it was highly mediatized. It was a very hopeful message for a disease, or better, a syndrome, for which that was considered mostly hopeless and the death of the century, it was called in the 90s, etc. And in 2020, the same authors added 3 more risk factors. So on total, 12 preventable risk factors, which you can see it's all over the life course. And what is interesting, actually, that education and hearing loss seems to have the highest impact, although these are factors that are less discussed, in my opinion. In the media recently, we have heard a lot about loneliness as a risk factor, and I think this can be seen as very positive. This discussion, in a way, helps us to think of loneliness as a social problem. And when at least in the interviews I made with geriatricians, when they talked about the whole phenomenon, in the short, they talked, well, it's about diabetes and hypertension, which were the iconic diseases they were talking about. And maybe this is because these are the conditions that are most easily medicated by pharmaceuticals. And in 2019, there was a third report which showed that close to 1 in 2 cases of dementia could be preventable in low to middle income countries. And I don't want to discuss, there's a whole discussion if these are too optimistic or not enough optimistic. But what I find fascinating in this whole report publication is that if you really look into it, it has become a biosocial phenomenon. Because why is it less in middle income countries? That's why, because risk factors are much higher normally, not always, in poorer groups. And this has also been shown because some groups, privileged group, dementia cases are declining. So on the bottom, if you look at this phenomenon, it has become, if you frame it in this way, a highly social problem, a political question, because as authors and researchers have shown, those groups where dementia cases actually declined These were groups where people had good access to health, to the health system, to the social system, and to the educational system. So I think the whole question has become highly social and political. And of course, there are two main explanations why this already lingering problem that has been discussed for a long time. And I recently interviewed a neurologist from the US, and he said, I defended this already at the beginning of 2000, and people were just saying, oh, he's crazy, and there are not enough evidence-based studies. I think, first of all, people became more and more aware that dementia, late onset dementia, is increasingly merging with aging in general. So, like here, Richards and Brain, who wrote, in older age groups, Alzheimer's seems to be a diffuse clinical syndrome representing the gradual accumulation of multiple pathology. So it's a kind of breakdown of the organism. And of course, Big Pharma became very interested also in this phenomenon and is financing it because we all know that Alzheimer medications don't work or work very little, and some people say they even do harm. So very quickly, what we call the new dementia is that it is opening up the cognitive paradigm. The cognitive paradigm is a term coined by German Barriers, a historian of psychiatry, who said that before it was taken for granted that the impairment of cognition would define the whole dementia phenomenon and also the treatment. It also goes a little bit against what social scientists call neurocentrism, that the brain is explaining Western individuals, or that it can be reduced in a certain way. But as we can see with the new dementia, its brain is becoming body, right? Because prevention now has become at least partly a phenomenon that is linked to the body or to social circumstances. Of course, it's only a third, if these numbers are right, and I very much doubted that this is true for everybody. The whole opening up very quickly happened at the end of the 90s, in my opinion, when the category BPSD, behavioral and psychological symptoms of dementia, became an official category, showing that not only cognition, but also, behavioral and psychological symptoms are part of the core syndrome of dementia. And of course, part of this whole phenomenon, and I'm sure other speakers talked about this, is MCI, mild cognitive impairment, and this whole movement towards early detection and early interventions. And this, of course, is not publicity. I just want to say that this first part has been published together with my dear colleague and friend Silke Schicktanz, and there you could deepen a bit my argument. This was a very, very quick overview. So my second argument is that clinical trials, at least those in 2017, need to be seen as situated. You all know what Donna Haraway wrote in the 90s about situated knowledge, that we have a responsibility and accountability toward multiple existing or possible moral narratives. In situatedness, it's less essential than culture, and here it is defined as the dependence of meaning and or identity on the specifics or particular socio-historical, geographical and cultural context, social and power relations, and philosophical and ideological frameworks. So in order to take care of the complexity of the whole phenomenon and not just reduces to a general, it's cultural. And there are different ways of situating prevention of dementia. For example, as I said already, in some richer nations, dementia numbers are going down. So, which we can say the healthcare system of a country or of a group or of a region needs to be situated. It's not all the same. We can also say that the science discourse is situated. For example, the turn towards integrating preclinical phases into the definition of the dementia itself will happen more likely on the North American continent. And this was a statement actually made by Peter Whitehouse, who told me that in Europe, this whole mild cognitive impairment movement is much less accentuated than in North America. Media images might be situated, for example, but this historical, some studies have shown that people with dementia before were portrayed as people who are passive, dependent, almost no person anymore, while now they're often showed in the media as active people, still connected and fighting for their rights. So there has been a major shift in public images. And finally, we could, as many critical public health scholars in general have written about public health, saying that it's ethically questionable, as May says here, and if we ignore systemic factors and put public health on the individual. I think you all heard about this argument before. So in 2018, I published an article in which I compared the major clinical trials that target prevention of dementia. And you can clearly see here that in the US, it's mostly about medication, while in Europe, it's mostly about lifestyle changes. And we could ask ourselves why, because it's generally circulating knowledge, but still there is a quite a strong difference between these two continents. And here on this next slide, it goes on, and on my article you see a larger table, but you can see again that it's quite visible that in the US it's mostly about a drug, while in Europe it is about lifestyle. And here's another example. I won't read all this, but it shows again that in the US it's more about a drug, while below the intervention might be lifestyle changes or measures to affect the risk of an individual developing dementia. So it's about lifestyle changes. Of course, this whole division, even in 2017, was not so clear-cut, and there were all these global international initiatives, mostly funded by the pharmaceutical industry. And so here you can see the opposite. The UK-based Dementia Discovery Fund is actually about drugs and the contrary. And today, if you look at the long list of prevention-related clinical trials, they are mostly pharma-based. But still, there in the beginning, I think it's an amazing data to think about that the same knowledge resulted in different initiatives. On this slide, I won't show you the films, I don't have enough time, but the first is about when this Lancet report came out. There was in Europe a short reportage where people were talking about public markets and jogging, etc., while one of the most important Alzheimer researchers in the US also explained it to the American public by saying that at the end, they think that it will be possible to develop a medication just like for AIDS and for cancers. So again, what I want to say here is that the same information can result in different translations. And you all heard, at least those who studies Alzheimer's, this kind of intense discussion, this big hope that people put into this drug aducanumab. I can't even spell it and not even talk about it. Which is based on a logic that treatment needs to start at a very early age, and it's based on this much debated amyloid hypothesis. It got a fast track designation from the FDA, which is only given to very, very promising drugs, and based on a phase 1 study that seemed to show that the compound could switch off the production of amyloid in the brain, which later on became contested. It enrolled over 3,200 patients, but in March 2019, Biogen Eisai announced that patients treated with this experimental drug, that was tested actually on people with mild or moderate Alzheimer's disease, so early on, showed no cognitive improvement after 18 months. And this was a big deception. Patients and families had put a lot of hope into it, even practitioners. But what is interesting actually are the reactions to the failure of the phase 3. These studies were called Emerge and Engage, and in Europe it was called Prime. And on the ALZ forum, which is a professional discussion list, there were three kinds of answers. There was those researchers who believed that the antibody tested was not the right one, but that a similar antibody will finally be the solution. Other things that it was still too late, so that the same compound, but at an even earlier stage of Alzheimer's, need to be considered. So it's actually just put it earlier and it will work. And finally, there was those that criticized the underlying amyloid hypothesis and see prevention as the only possible pathway, at least at the moment. So if we look at the reactions, here is one from David Holtzman from the US. He said, even though this trial was in the early symptomatic phase of Alzheimer's, it's still in the phase when amyloid is no longer likely to be the driving process, but where tau and inflammation probably are. I think amyloid is still a good target for the primary and maybe secondary prevention trials of Alzheimer's before tau and inflammation have started driving the disease. Stefan Sensi from Italy, however, he wrote, the failure of the phase 3 trial is another warning that the field must take a different approach. Some authors have already called for a rejection of the amyloid hypothesis. Alzheimer's is a multifactorial condition in which, along with beta amyloid accumulation, the convergence of many genetic, environmental, vascular, metabolic, and inflammatory factors promotes the neurodegenerative process. We need to remind ourselves that a third of Alzheimer's cases are strongly dependent on the concerted activity of modifiable factors like low education, midlife hypertension, midlife obesity, diabetes, physical inactivity, smoking, and depression. It's time to take up the challenge of complexity. And I think this is a very interesting statement and different from the first one. Here's some more example. Kasper Kapp from Denmark, he wrote, it has been known for many years that the amyloid hypothesis cannot be correct. The reason it survives is because it is appealingly simple and offers a one-sided treatment strategy that pharma can pursue easily by antibodies and inhibitors. Unfortunately, these people include, because of the paradigm's previous popularity, major opinion leaders in big pharma with the responsibility for listening to only some key opinion makers of the dominating paradigm in the time of its sunset. So until now, you can see that the US representative, Holtzman, which I gave here as an example, is much more in favor and thinks it should maybe start earlier or maybe another antibody should be used, while the European, here Kasper Kapp and Stefan Sensi from Italy, actually criticize the underlying logic. But of course not all Americans. So this Ron Peterson from the US, right? Might they work prior to the development of symptoms? Maybe. But with no symptomatic signal, it's risky to continue in that space, and we clearly need other targets, and tau is the leading candidate for now. So he's a little bit in between these two. A second example, I'm doing a lot of my fieldwork, and I think my time is almost over, so I will be very quick. In Brazil, I'm doing fieldwork on aging Alzheimer's dementia, mostly in the geriatric setting, but here you can see that it was a land-wide initiative. They constructed very expensive, actually, like playground exercise places for old people, but which, as you can see here, are empty. It's probably because they have been framed as a space for older people, and older people don't like so much to be considered older people, but also because it's a very individualizing. When these places started, they had teachers, so people were meeting in groups and they had fun together and it worked well. But then when no more money was there and the teachers did not exist anymore. People had to do exercise themselves, so no one came anymore. Just as a small example of the materiality of this whole prevention, and that framing is an important aspect here. So as a conclusion, what I was trying to do is to call attention to what, in the name of Donna Haraway, in a way that she talks about possible moral narratives. So we have seen that this circulating knowledge is being translated in different ways, in different contexts. It can be translated in the most simple division into individualizing or structural measures. If we see that it's a social and political problem, of course, it is about providing a good life that will probably also result in better aging. If we translate it into individualizing practices, this is much less given because we all know that there are other factors behind. And I just want to finish with one quote. I quoted it quite often because I love it so much. In 1905, we found in the Journal of Preventive Medicine, Crichton Brown, who wrote, in 1905, Americans break down at an earlier age than Europeans, especially from nervous ailments. And he refers to his colleague Dr. Hamilton, attributes this to their struggles for the rapid accumulation of wealth, to the competition and ambition which are largely stimulated by agitational newspapers, to hustling, overeating, insufficient exercise, and luxurious living general. Thank you very much. And I thank especially Silke Schicktanz, Perla Werner, and Zümrüt Alpinar Sencan. Thank you very much.